I think with that we come to the last talk of this session by Dr. Sumita Agarkar. Everyone knows her, she doesn't need any introduction, and she'll be talking on Duane syndrome, which is again a very difficult and complicated situation to diagnose and to manage.
Good evening, and thanks for being here despite being the last session of the day. So Duane syndrome, as we all know, is now been reclassified as cranial disinnervation syndrome, has variable clinical features, which is the main parts are basically a motility limitation in combination with features which are suggestive of tight muscles. So just to get a recap, Duane syndrome can have limitation, as I said earlier, limitation of ocular motility, strabismus, narrowing of palpebral fissure, upshoots, downshoots, and abnormal head posture to overcome any of the above or for maintaining binocular single vision. So classically, we have all learned about Huber's classification, but I think based on primary deviation, it is more useful from surgical planning point of view to classify them as esotropic, exotropic, or orthotropic Duane syndrome. So ESO-DRS, mostly esotropia in the primary gaze, may have head posture like this gentleman, and sometimes palpebral fissure changes as noted classically in the literature. This is a patient with exotropic Duanes. As you can see, limited adduction, but not so much of abduction, and not so much of narrowing of palpebral fissure, but a head posture. So when you're looking at esotropic Duanes, which is most likely to be confused for lateral ictus palsy, sometimes occasionally infantile esotropia, they can be classified for Mobius syndrome as well as sometimes rarely oculomotor apraxia. So the only thing which you have to differentiate from Duanes and lateral ictus palsy is to look at the primary angle deviation. If you look at the picture above, which has lateral ictus palsy, both of them, if you see here, have dramatic abduction limitation. But if you look at their primary gaze, there is a fairly large angle esotropia in the primary gaze in the patient with lateral ictus palsy, while this child with Duane syndrome, despite having a fairly marked abduction limitation, has almost straight-looking eyes. So why these patients need intervention? For this variety of reasons, but most important are these which I have mentioned in this slide. So when to do nothing? Before we plan surgery, you should also know when to do nothing in case of Duane syndrome. If there is a minimal head turn or a small angle strabismus with good functional binocularity, you should not do anything. You should also not do anything if patient has any unrealistic expectations out of surgery. So if you see this child has a minimal face turn, the slides are moving by itself. So this patient, I would not recommend doing any surgery except watching carefully. So if you are looking at operating for strabismus, it's not only the primary deviation or the amount of deviation which is important, but also you have to look for incorporating Is he moving from there? It's automatically moving forwards. Go back 2 slides.
It's not moving?
No, it's moving by itself. It has a life of its own.
Now things don't move.
Yes. I think it's divine signal that finish fast.
Trying to keep time.
Yeah, keep to the time. So when you're making surgical plans for these patients, you look at the magnitude of the deviation as well as FDT and the amount of anomalous lateral ictus innervation. You have to remember that these patients, most of the abnormalities are driven by an abnormal lateral ictus, and amount of that anomalous innervation determines a lot of issues which you see with Duanes. So in esotropic Duanes, which is most frequently seen, you may have to do surgery for any of these reasons which I have mentioned here. And you need a customized approach for this entity. Esodeviation, which is small in nature, like up to 20 PD, can be corrected with just one medial rectus recession, again depending on FDT. If FDT is tight, do less. If FDT is not that tight, do more. However, if FDT is negative, probably it's better to do a partial VRT or SRT, both of which can be, as published by Dr. Pradeep Sharma, can be done on adjustable cross-action ways also, and can be made adjustable to give you more control over post-operative result. Coexisting upshoots can be treated with Y-splitting of lateral rectus if there is significant upshoot there. However, if the angle is large, then you may have to do a bilateral recession. Again, asymmetric bilateral recession is preferable. Asymmetric means less in Duane's eye and more in the normal eye. Again, medial rectus can be combined with a SRT or partial VRT to give more results, to correct more of strabismus. Lateral rectus co-contraction, if it is there, then VRT or SRT is not a great idea, and in that case you may have to actually do a lateral rectus recession along with bimedial recession. Bilateral cases, which are rare but can happen, and they also do well with bimedial recession combined with SRT or just IRT or even partial VRT. So this gentleman, as you can see, has a isotropic Duanes with a face turn, and all we did was asymmetric Duanes with fairly good alignment as well as correction of the head posture. This lady, however, has had a very, very large face turn with a esotropia, and here we have done medial rectus recession with SRT, and you can see it's not fully corrected everything, but head posture is so much better than, say, here to here, where if there are significant upshoots and downshoots due to anomalous innervation, you may have to, it can be managed surgically by Y-splitting the lateral rectus, or sometimes if it is very anomalous innervation, you may actually have to take a periosteal fixation of lateral rectus or completely disabling the lateral rectus to get all of it corrected. This patient, as you can see, has a head turn, a really significant upshoot and abduction limitation. And here, after my Y-splitting, I just did a medial rectus recession and Y-split. Head tilt, head turn persists. There is probably a small esotropia still remaining, and but her head. Exotropic Duanes is less frequently seen. More associations of lateral rectus co-contraction are present in these entities. And exotropia can be managed by large recession, and it's like really large recessions. And sometimes you may have to combine it with a Y-split if there is a really severe upshoot. Again, periosteal fixation may be required if there is absolutely no normal lateral rectus activity in abduction. So this is this girl who you can see in the she has a fairly face turn and a really, really large upshoot and an exotropia in the primary position. And we did a lateral rectus recession along with Y-split, and most of her issues are sorted out. Although when she came back 6 weeks later, this is first post-op day, she looks much better in this picture, but when she came back 6 weeks later, she still had a little bit of face turn and may need additional surgery. So again, abnormal head postures are mostly to compensate for esotropia or exotropia, but sometimes also to avoid upshoots and globe retraction. So this patient clearly has esotropia and compensating for esotropia by head posture, but this gentleman has an head posture to avoid the co-contraction and the upshoot which is there. And post-surgery with Y-split, as you can see, his head posture is so much better because his head posture was not directed by strabismus, but by the severe this. Now this is something a new kid on the block and can be considered in very young children. There is only one paper on this by Dr. Kumar Senna, that if you diagnose Duane syndrome less than 1 year of age, Botox can obviate the need for surgery and can also cause complete resolution with a single injection with younger children. What can go wrong post-surgery? Overcorrections happen. Sometimes you can induce torsional diplopia following SRT or VRT, and sometimes in transposition procedures, you can also induce new vertical strabismus, which was not there earlier. And in that, if any of these two things happen, it is best to explore as early as possible in the postoperative period. And this must be, especially if you're trying or planning transposition, this must be discussed with the patient before you do the surgery. Thank you for your attention.
Thank you, Dr. Sumita, for covering a very diverse and difficult topic in such a short time. I would just like to say that I think refractive correction is important in these cases. Quite often they are hypermetropes.
Yes.
And if you can even correct the deviation, because they could be having an accommodative component, and that may be the only thing which may be required. So refraction amblyopia is not very common because they manage to adopt an AHP, so they don't have amblyopia that often because of the strabismus. Otherwise, they can have amblyopia. And then, of course, MR recession one should be careful. If there is more contraction, then you should not do too much of MR recession because it may send the eye into an exo. So that is also important to keep in mind, that you be slightly careful with MR recessions in these cases.
Less is more.
Yes, less is more. And bilateral cases have a lot of genetic issues. So if you have bilateral case, think of genetics also. So I think, Dr. Pradeep, would you like to say something?
I think you have summed up all the additional concerns.
Yeah, and I think shoots and globe retraction are most difficult to handle, I think. Some residual thing quite often will remain. Deviation HP is still easier to correct, but shoots, those bad ones and bad globe retraction, I think they are very difficult situations. Anything, Dr. Pradeep, like to say something? Dr. Shreya? Dr. Subhash? So, Dr. Pradeep?
I think we're done.
Can give some concluding remarks?